Thank you for joining us for today's webinar, the Top 10 Patient Safety Concern Challenges Transitioning Newly Trained Clinicians, presented by ECRI. My name is John Schmidt. I'll be helping moderate today's webinar. And we have people joining us from coast to coast to coast in Canada and from many places in the United States today. So welcome to everyone. It's our pleasure to have you. Out of respect for all treaty and non-treaty territories and people in Canada, we acknowledge and respect Turtle Island and all its Indigenous nations, including First Nations, Inuit, and Métis people, and ECRI remains committed to truth and reconciliation in Canada and everywhere. Today's webinar is being recorded. We'll share a link to the recording with you after the event is complete. And we also invite your comments and questions. So please see the Q&A chat box on your screen. If you have any questions for the speakers at any point, please type it in the chat box and they will be answered during Q&A towards the end of the presentation and webinar. Any questions that are not answered will be addressed after the event. We'll be happy to get back to you. So please note our contact information and we'll be in touch. So I'm John Schmidt, the Regional Account Executive for the Canadian Health Solutions and Government Affairs arm of ECRI up in Canada. I'm physically located in Victoria, BC. As I'm going to introduce our speakers now. So as the inaugural Michael Guerin Chair in Patient-Oriented Research, Kelly Smith is the Interim Chief Scientific Officer at the Michael Guerin Hospital and Associate Professor and Co-Lead for Outcomes and Evaluation in the Institute of Health Policy Management and Evaluation Graduate Program at the University of Toronto. Dr. Smith's research focuses on co-producing practical solutions to challenges of healthcare delivery with a focus on patient safety through the application of improvement science. Dr. Smith is a leading researcher funded by the Agency for Healthcare Research and Quality through the Patient Partnered Diagnostic Center of Excellence and a Patient Safety Learning Laboratory, aiming to identify the challenges for women in receiving an accurate, timely, and communicated diagnosis of heart disease. So welcome and thank you very much for joining us today, Dr. Smith. Dr. Duscher is an adjunct professor at Thompson Rivers University School of Nursing and founded a nonprofit organization entitled Nursing the Future. Her early career was focused on developing expertise as a direct care nurse, researcher, leader, and educator in cardiothoracic and high acuity contexts. For the past 25 years, Dr. Duscher has been an active researcher and consultant in the area of new graduate professional role transition, which we'll be talking about in depth today. The findings of her research generated a theory of transition shock and model of the stages of transition, and constructs are being used globally in the preparation, orientation, transition, integration, and stabilization of the newly graduated nurse. In 2020, she was seconded by the Canadian Nurses Foundation to reestablish Nursing the Future as the national platform of support for nurses in Canada. Shannon Davila currently serves as the Executive Director of ECRI's Total Safety Systems. With a clinical background in adult critical care nursing, Shannon specializes in infection prevention, patient safety, and healthcare quality improvement. She currently sits on the National Steering Committee for Patient Safety. She has authored a book and published several articles that focus on the importance of infection prevention and patient safety. In 2016, Shannon was honored with the AIPC Heroes of Infection Prevention Award. So thank you very much for our speakers for joining us today. They're all over Canada and the United States. So this is a truly global and international webinar, and it's a very exciting topic. And personally, I just want to say that Dr. Duscher was one of my nursing instructors over 25 years ago when I was a junior nurse. So it's always a pleasure to reconnect and come full circle in your academic and professional careers. So thanks for joining us, Judy. And with that, I'll hand it over to Shannon.
Thank you so much, John, and welcome everyone. We're really excited to have you all on today. And of course, thank you to our esteemed guests and our speakers. So we want to just, before we jump into the exciting discussion, we wanted to give you a little bit of background about ECRI. And we are headquartered in Pennsylvania. However, we are an international organization, as you see by the image here on the right. And we do a lot of work around patient safety, device evaluation, and evidence-based practice. We are a nonprofit organization. We're very mission-oriented. Just some highlights of ECRI. We are, as I mentioned, an evidence-based practice center. We're only one of 9 certified by AHRQ, the Agency for Healthcare Research and Quality here in the United States. We do a lot of what we call horizon scanning for agencies to see what are the issues coming on the horizon, how can we better prepare providers and patients for what's coming in the future. We are, as I said, a patient safety organization. We're actually the only organization in the United States that is both a patient safety organization and an evidence-based practice center. We are partnered with the Institute for Safe Medication Practices, or ISMP. Some of you may be familiar with ISMP. They also have a branch in Canada. And we are the only independent testing laboratory, device testing laboratory in North America. And what that means is when there are certain devices, ventilators, IV pumps, devices that many of you use every single day, organizations send those to us and we provide an independent evaluation of those devices. So we can tell providers and manufacturers how safe post-market devices are. So we do all of this. Now, let's get to the learning objectives for today. So today, we're specifically going to be talking about our #1 issue on our top 10 list, which was around the challenges of transitioning newly trained clinicians from education to practice. So we'll talk about some of the post-pandemic contributing factors that made those transitions difficult. We're going to talk about some of the impacts that these factors have had on patient safety and patient safety culture. And then we're going to then dive into improvement strategies. And we're going to highlight some multi-system level approaches. And we've got some great examples here today that our speakers are going to share with you as well. And we hope that through all this, you will be able to take away strategies back to your leaders to think about your own practice and how you can improve the transition for these new clinicians. John has already introduced us, so I will just skip over this piece. And the last thing I'll say about ECRI is pictured here is our founder, Dr. Joel Noble. He founded ECRI over 55 years ago. And originally our name was the Emergency Care Research Institute. So that's where the ECRI came from. And just a fun fact for all of you, what he is leaning on in this photo, it is not a desk. It is actually one of the first prototypes of what we all know now as a code cart. And Dr. Noble was actually working in a local Philadelphia hospital one day when he had a pediatric patient that went into cardiac arrest. And the defibrillators, or the resuscitators, they called them, that he tried to use failed. And so he created a prototype. And what's really interesting is that that arm looking thing that has, it sort of goes up, it's black and then over and it's white and then has like a black piece on it. That is actually a chest compressor. So the patient, they would slide the patient on this platform here, and then the chest compressor would come down. Now, what's really interesting is that there are only 2 versions of this left in existence. One of them is in our headquarters building, and the other one is actually in the Smithsonian Institute Museum in Washington, D.C. So just a little fun fact for you. All right, so let's get into this. When we talk about complex safety issues here at ECRI, we really like to think of it through the systems lens. And so I always like to say this, that every system is perfectly designed to get the results that it gets, right? So if you are experiencing issues within your organization because new nurses or new physicians are making errors, or perhaps they're not asking the right questions or engaging with their preceptors the way that we would expect them to, it is generally not the fault of that person. It is because your system has designed to get those outcomes. So if you think about it, this isn't to place blame. This is just to say, if we want to fix problems, we need to think about it from a systems perspective. And so that's what we do here at ECRI. And we think of, any kind of complex issue, patient safety, worker safety, patient family engagement, whatever it is, we look at it through this lens. And so you see over here on the left-hand side, we have our system. And of course, you have the external environment, which can be many different factors, right? It can be regulatory, it can be, payers, it can be, research. But then you have within the internal environment, and this is where most of us as healthcare providers, we operate. And that's the physical environment in which you care for your patients. And when we think about newly trained clinicians, generally, that can be acute care, but we're seeing more and more newly trained clinicians that are transitioning directly to ambulatory settings or long-term care settings. So it's that physical environment in which they work. The tasks and processes, these are the steps that we want our clinicians to take to accomplish to conduct that safe and effective care and service delivery. Tools and technology. It's important to think about this, especially as we are literally skyrocketing into the age of AI and, but we still have people that struggle with their electronic health records, right? I think, we were thinking about the application of AI, but a lot of us as nurses and physicians, we're challenged with just getting the orders and getting our documentation. And so tools and technology play a big role in how healthcare providers in general, but especially newly trained clinicians, how they're able to prioritize and really, figure out how to accomplish those tasks. The organizational factors. So this is your leadership, it's your culture, it's your resourcing, all of those pieces, which can either help or hinder how that care is delivered. And then at the center of all of this, we see both the team members and the patients. And so, of course, a lot of people talk about patient-centered care. We really like to talk about person-centered care because it is about protecting and caring for and supporting those team members so that they can deliver that effective and excellent care to our patients. So this is the lens that we look at. And when we think about complex safety issues, we want to find out all of these factors that could be leading to the issues. And we can apply this to the topic that we're talking about today, right? About how can we better prepare newly trained clinicians to make that transition into a safe and effective a healthcare system in which they can deliver the care that our patients really need. So let's, when we talk about solutions also, because when we talk about what the issues are, we don't want to just say, well, here's the problem, good luck. We want to say, what are some potential solutions as well? So when we think about solutions, we really frame our thoughts around these 4 sort of pillars of what we call total system safety. And that is that we need to cultivate leadership, governance, and culture that really reflect that deep commitment. That our leaders, they understand what the safety issues are, and they're not just talking the talk, but they're walking the walk. Engaging our patients and families as a true co-designers in their care. And this is more than about just assessing for their experience after they've left the healthcare institution, but it's about really understanding what their goals of care are and how we can collaborate with them to meet those goals. It's also about fostering a healthy, safe, and resilient environment for the workforce. And we're going to talk about that today too. That's a big part of setting up our new clinicians for success, is making sure that they're in an environment that is truly supportive of their needs. And then finally, but certainly I think maybe one of the most important parts is that continuous learning and shared lessons in order to be able to enable organizations to learn. So looking at your data related to harm events, different, safety culture data, how that's, when you stratify that from, experienced clinicians, more senior clinicians to those that are new to the organization or newly trained. I think there's a lot of lessons that leaders can gain from looking at that data and then truly becoming a learning system where you can improve and become more proactive and highly reliable moving ahead. So that brings us to our top 10 patient safety concerns list. And we do publish this list every single year. We have published it for over 10 years now. And you see here that our list actually covers lots of things from that circle I just showed you. We have things around barcode administration, so that's tools and technology. We have things around providing equitable care for people with physical and intellectual disabilities. That's really about, that person-centered care. But at number 1 on our list, and what we're going to focus for today, is the challenges transitioning newly trained clinicians from education to practice. And I would encourage you all, I believe we'll provide the link to download our top 10 list where you can read about all of these issues and solutions for all of them as well. So let's get into the main issue here. Now, I think probably many of you have felt this, experienced this, but we know that the pandemic had a major impact. And from the Registered Nurses Association of Ontario study from 2023, I really liked this quote, but they said that the pandemic created a new risk for both staff and to patients, whereby it was not uncommon for nurses to be asked to work outside their scope of practice. And where this did occur, they were not always supported with education and training. I'm sure many of you can relate to this and had this similar experience. Now, imagine that for a staff member that is new to the practice and how scary that can be. And this is for nurses and physicians and pharmacists and others, right? Our respiratory therapist colleagues. But that to be placed in that kind of uncomfortable situation, the pandemic just elevated that altogether. And we know that there's lots of data that came out that showed that, again, this wasn't just related to nurses, but medical residents. There was decreases in hands-on education and training, particularly around high-risk areas like surgical specialties, neurology, and anesthesia. These are critical learning experiences that physicians and nurses, really interdisciplinary teams, need to have. And a lot of them were not able to get that high level of training that under normal circumstances they would have received. And the disruptions, it's loss of practice repetition, changes in orientation, and then, as many of you remember, the policies were changing every single day, right? It was every single day there was a new protocol about wear this mask, wear that mask, we're going to prone our patients, we're not going to prone our patients. And so it was just a situation that was very difficult for new grads and new clinicians to keep up with. Reduced mindfulness around culture of safety. And, this is really thinking about how newly trained clinicians think about the importance of reporting near misses and harm events, how they feel supported by their leaders. And in ARC data from the Culture of Safety Survey, only 33% of clinicians who have worked less than 1 year in their work setting had voluntarily reported one or more safety events. Now, that's a 33%, but when you compare that to clinicians that were much more experienced, 50% of them had reported more than that. So we're seeing what we call this lack of agency, lack of sense of agency around understanding the impact of culture of safety and why it's important to speak up and to report safety events and to really provide that feedback to our leaders. So this is something that we should definitely think about. And then really on top of all of this, we have the workforce crisis, right? So to add insult to injury, I guess, right? So now we see that there are studies that show that 42.5% of new graduate nurses reported they were considering leaving the field of nursing. That's almost 50% of new grad nurses. Physician burnout rate is over 60%. This is huge. In a study of Canadian nurses, estimated shortages in an excess of 100,000 nurses by 2030. And I'll tell you, 2030 is just right around the corner. And a quote from the Canadian Nurses Association president, retention is the absolute priority, or the situation will worsen. Our next priority should be recruiting more nurses. We will also need to ensure that nurses are not only working to the full scope of their practice, but that can be expanded to increase their productivity. It's important for leadership in both nursing and medical fields to speak up and to really call this out and to be part of the solution. So we're happy to see that the associations are behind this. So that's a little bit of the background. I want to start talking about some of the solutions, and then we're going to transition to our speakers to really get into some wonderful details about some specific things that they've been part of and they've seen. So let's talk about how leaders can help, improve this situation. So you see over here, many of you have probably seen this, but this is a great toolkit, the Nursing Retention Toolkit, and a tool that I think all nurse leaders should be familiar with, and really understanding how, I love it because it looks at nursing retention through an operational lens, which is, I think, what we need to do, because you can't look at retention in a silo. You have to think about how that impacts your clinical and safety outcomes as well. And really think about those retention activities that are going to not only support, but fulfill your clinicians and make them not only feel that they are safe to come to work, but that they are proud to come to work, that they are excited and that they are able to do what they came into healthcare for, which is to provide that care to patients. Additionally, supporting the development of robust transition to practice programs. And we're going to hear from Dr. Duscher in just a moment about her program, Nursing the Future, which is an amazing wealth of resources around how to really build those strong transition skills and tools for new nurses. From a patient and family engagement perspective, there's lots of great tools out there. And I wanted to highlight a couple here. The Agency for Healthcare Research and Quality has a wonderful toolkit, which is their toolkit for diagnostic safety for patients and families. But they have what's called the 60 Seconds to Improve Diagnostic Safety, which is almost a train the trainer program. And you're actually going to hear from one of the leaders of that toolkit in a few minutes also, Dr. Smith. But it has a piece of that which helps to engage providers to become better listeners, to understand what their patients' needs truly are. And this is a tool or excuse me, a skill that I think, we can't assume everybody feels comfortable with the skill of listening, particularly newly trained clinicians, right? They're so focused on their clinical skills that being a good listener and really being in tune to some of those needs that aren't as apparent, that takes maturity and practice. So this is a great tool to really help people develop those skills. Rethinking patient safety is another tool, establishing safe connections that go beyond preventing harm in the roles that everyone has in delivering and receiving that care, how they can play there and play with that, excuse me. And then engaging patients as partners in care with the Patients for Patient Safety Canada resources. So I just want to point those resources out. Now, workforce safety and wellness. Again, ARC has some really great tools. They have their workplace safety supplemental items. If any of you, as part of your assessing culture of safety with your teams, if you use the culture of safety survey that ARC has, they have a subset of questions that are around workplace safety that you can also ask. And again, you can stratify that data so you can really start to understand the attitudes, perceptions, and beliefs of those newly trained clinicians. You can look at the team members that have been with your organization under 1 year and start to compare their perception around worker safety compared to those team members that have been there longer. And I wanted to point out this resource as well from Switch BC. It's about thinking about safe work practices. This is an example of a community physician health and safety guide, but I think it's just a really great example about how it's, again, as you're thinking about growing and these strong, competent clinicians, we need to make sure that we're also making sure that they practice in a safe way as well, which is, making sure they have a safe environment to do that. And then finally, we'll talk, some solutions around learning system. Simulation, of course, is something that has grown. We know there's some great simulation work going on across Canada. There is a great tool here, the Simulation Canada tools that can be adopted by different organizations as you're building out different simulation for, either clinical scenarios, high risk scenarios. Certainly sepsis, diagnostic errors are big areas that people are focusing on. But I would encourage you to think about how you can incorporate patient safety training into those simulations as well. Perhaps near miss reporting, hand hygiene, central line care. There's lots of ways that we can incorporate that in. And again, these are skills that newly trained clinicians really need to practice to be comfortable with. So those are just some examples. We're going to transition now. I'm going to hand it over to Dr. Duscher, who is going to talk specifically around transition. So Dr. Duscher, the floor is yours.
Thanks, Shannon, so much. And thanks to ECRI for inviting me to talk about the experience of transition. I do think that we tend to focus a fair bit on the competencies and the skill development of these new practitioners once they get in. But what we don't always understand is the relationship of the experience that they're having of making this transition with their ability to enhance their capability, because they have the capacity. I try to help people distinguish between the capacity, which is, you know, endless, and the capability, which is right now, what am I capable of doing? Slide. So I just wanted to point out that I've been in this business of transition for a very long time, and feel like as I've refined my work and kept contact with those direct care practitioners, be they nurses, physicians, or allied healthcare professionals, I've learned sort of the nuances that tend to change, but for the most part, my work is saying that there is a process of transition that all graduates will go through, including physicians, but not all aspects of that transition experience will be weighted the same accordingly to different people and different professions. Slide. So, you know, not much has changed when it comes to how these individuals experience their transition. It is an incredibly difficult period of time. It was before COVID. And certainly, you know, the pandemic introduced a lot of variables, as you outlined quite nicely, Shannon, that included the inability to have the numbers and the experienced practitioners to support these new graduates coming in. And even if they were there, they were going through a very difficult experience with COVID themselves and weren't necessarily available. And then, of course, there was the tremendous change that was occurring on a daily basis, not just to policies and procedures, but to actual work expected of the nurses in those practice areas. So what new graduates need, according to my research, is consistency, predictability, stability, and familiarity. And a lot of those just weren't happening as a result of COVID. So it really threw them into a fair tizzy. A slide, please. So why should we care about this? Well, the majority of nurses in particular going into practice go into an acute care context, at least in part. And sometimes they're able to you know, get a few different roles in public health, for instance, or the community in some way, but most of them go into a form of acute care. And we know what that's like these days. There's staffing shortages, just thinking about the multiple generations. And speaking of that, the loss of some of the generations and their intellectual capital that went with them. And one of the strategies I've definitely recommended is to bring that back, because, and not into backbreaking work that we normally think of when we think about nursing work, but rather bringing back the knowledge capital and bringing back the ability to mentor these new graduates from a cognitive perspective. And certainly we have a changing demographic. The things that they want from work are just not the same as the things I wanted out of my work. In fact, I didn't expect much out of my work. I expected to go to work and get paid, and that's about it. But that's changing. The quality of life expectations of new practitioners is just different. And you can see why. I mean, they're looking around at a world that is incredibly uncertain and precarious. And they're thinking, this is not going to be my life. This will be a way for me to live my life. The subsequent exhaustion from a lot of the work that's expected is influencing their job satisfaction. And I just went to one of my doctoral students' defense, and her research will just be coming out. It's incredible. It's on the decision-making clinical judgment of newly graduated nurses. And one takeaway from her research over a number of years was that these nurses think they're going to be doing one thing, and they get in there and realize that nursing is so much more and so much more complex than they ever thought it was. Yet they're not really able to do those very value-based practice events that they thought they were going to be able to do: care for people, spend time with patients and families, teach, all of those pieces that we tell them they're going to be able to do. Slide, please. And so my work has identified 3 stages. There's the pre-graduate piece where they're doing their final practicum, and I think a lot can be done in that final practicum that we're not necessarily doing, and that really depends on the nurse's capacity to mentor and to pass on their knowledge and to spend time, which is exactly what they don't have a lot of times in practice. And so then they move into stage 1 once they are independent practitioners. So once that orientation piece is finished. And there's an element I identified called transition shock. And it's really quite robust and quite comprehensive and includes issues related to roles, responsibilities, relationships, and knowledge application. And those are the feature pieces of the new graduate transition. And if they, if they do well in that initial stage, which is a bit disorientating, they move into stage 2, which is more about integrating. And this is where they can move back and start to see everything that's going on and are oftentimes really quite baffled by the system. And I think this is where we tend to lose them. We don't tend to lose them in stage 1 because they are just, head down focused. But stage 2, they lift their gaze, take a look around. And this is, I think, where they're making decisions whether or not they're going to leave. In stage 3, you hope that they're starting to stabilize their experience and feeling welcome and feeling like, yes, I am contributing the way I thought I would contribute, or at least I can reconcile the pieces that aren't working for me. Slide, please. So I mentioned this before, but in the transition shock construct, I speak to roles, responsibilities, relationships, and knowledge, mostly application. And there's a lot of detail in this work that I'm not going to go into today, but primarily, I think you need to be able to assess which of these 4 quadrants is most problematic for the newly graduated nurse, because sometimes one is far more prominent than the other. And until you can target that area, you're really not going to see those graduates progress. And I have more information on that on the Nursing the Future site for anyone who's interested. Slide. So the foundational elements I did also mention. Graduates generally in any profession require stability, predictability, familiarity, and consistency in order for them to continue to move forward. So and this is both personal and professional, and this is why COVID really took the knees out of a lot of new graduates, is because even though the workplace might have been familiar, what they were dealing with when they got home was not familiar to them. Changing in the garage, spending their nights sleeping in the basement, things like this that really threw them off. Slide. And so why does this difficult experience endure? Well, to begin, there's a subtle integration of theory into practice settings that varies according to the setting. There's a maturation that has to occur that only time can assist you with. And in terms of collaboration, it's important for new graduates to understand how to collaborate with others and then to have those people to collaborate with. And finally, expertise settles in over time. And so it's not just a matter of throwing all the resources at newly graduated nurses. It's a matter of giving them time to practice, to see different situations, and to cope with those situations with support. Slide. So the primary sources of new graduate error are truly medication. And primarily, a lot of the errors of new graduates have to do with they don't have the time or the experience to critically think through a situation. I mean, we teach them how to critically think, but to think critically, you require some background information. You require experiences that you can rely on and lean back on. Oh, I've seen this before, and this is what I did, and it did work, etc. And the delays in patient care that actually Shannon mentioned initially are fundamentally a result of the new graduates not being sure. And so this statistic that Shannon showed about the lack of reporting made perfect sense to me. First of all, you as a new graduate think the error is because of you. You never think that the error is because of the system. That's where you're at developmentally. So for you to report that error in any way to a colleague or through that crazy system that we have that takes an hour to report an error and put it on a computer and never hear anything after that, is not something I'd necessarily do because it exposes me as having made an error. Slide. And this sort of, reaffirms what I've just been saying, that, distractions to a new graduate, everything's distracting to a new graduate because they're not exactly sure how to pin down what's salient and what they ought to focus on. And so any conditions that disrupt that linear approach will fluster them and make them very unsure and uncertain about the actions that they're planning to take. So having someone to say, okay, I'm thinking of doing this. Does it make sense to you? Is it critical? Well, we don't have a lot of that in practice right now. We've literally got the blind leading the blind because we've had such high levels of attrition that we don't have that experience that allows us to support that new graduate. And understand that error and uncertainty for the new graduate is highly personal. This is a very emotional experience for them, and they take it very personally. Slide. I just wanted to point this out because regardless of how much knowledge you give to the newly graduated nurse, as is evident here, they don't really know necessarily how to apply that knowledge. So they may stick to an algorithm when you really need to deviate from it, or they may deviate from it when they really should have stuck to it. So they're not exactly sure how to do that. And that's where the experience comes in. Slide. And again, the expectation that they will function at a high level is still there. And it's even more so there now because we don't have those seasoned practitioners for them to lean on. And so it's not normalized that they should be novices. It's not normalized that they should not know. Slide. Just very quickly, this was an actual impression drawn by one of my doctoral students. And this is the new graduate surrounded by his or her colleagues. Slide. I think you can see this slide in the slides as you'll be able to review them later. So it's just reiterating what I had said. Slide. Thank you so much.
Thank you so much, Dr. Duscher. And now we're gonna transition to Dr. Kelly Smith.
Thank you, Judy. Thank you, Shannon. This is really exciting because everything that Judy has just explained, I feel like we are experiencing locally at a community hospital. And I'm just here to talk a little bit about how I, as a teacher and an educator, use the ECRI top 10 safety concerns, and also go into a little bit of depth into how we're operationalizing some of the lessons learned and how we're using it from an operational perspective. Next slide, please. Oh, next slide, please. Great. So one of the delights of my experiences and my expertise is that I get to work with healthcare leaders, the future patient safety leaders, in some of our master's and graduate programs at the University of Toronto. One of the key activities that we have towards the end of our patient safety course, an intensive course, is actually looking through and discussing and really helping to verify and validate some of the ECRI top 10 concerns that happens. It's released in March every year. So we have this activity that we work in small groups in April. And one of the key things is it really helps us to feel like we're not alone. All of the leaders read this and go, oh yeah, I have an example of this. So it's really nice to have that opportunity to share in a safe environment with your peers and your colleagues from other hospitals, other organizations, that this is something that you're seeing too. And then it provides an opportunity to share and do some of that knowledge sharing. What are you doing about it? How can we learn from you? how can we start to maybe go on the path that we're journey together? Or how can we talk to maybe our executive team within the hospital about making this a priority? So we do that. We spend about 2.5 hours on this particular activity. And it's one of the most enriching because it's really about our personal and lived experiences in our own hospitals, in our own patient safety journeys. So that's one way that we use it, both in education, but I brought it this year to our executive team as well. And it is something that is like, finally, yes, we're not alone. Because sometimes when you're seeing these patterns and you're wondering if you are alone and the literature is telling you, yeah, no, we're seeing this at other places, it's nice to have a place like ECRI who has such a broad lens really across the US to say, yes, this is happening in the United States. We also do that cross comparison between Canada and the US. Is this, are we seeing the same things? And over and over and over again, we actually see them. Next slide, please. So some of our big lessons learned, again, it's that we are not alone. It provides some practical solutions and strategies to get us started, because that's the other part of patient safety, is that you don't want to reinvent the wheel. There are people out there who are already doing this, leading this, and ECRI provides a really good platform with that document every year, with that report every year, to help us get started. Oh, there might be one thing that we can try, or we can all try together, and then create a community of practice. And so that's something that we really like to do from the education, and taking that knowledge translation and translating it into our own local hospitals. Next slide, please. So when Shannon asked me to speak, she also asked me to do some reflection on how has some of the wisdom that the ECRI report, as well as Judy's experience in transitions in particular, what are we seeing on the front lines? What are we seeing on the hospital side? How are we doing? How are we activating things? So I'm going to talk a little bit about the hospital that I'm an embedded scientist at. The hospital is Michael Garron Hospital. It's a large community hospital, sort of urban community hospital in East Toronto and Toronto, Ontario, Canada. And we have gone through a lot of change. Next slide, please. So the change is important because the change happened during COVID, or sort of mid-impact, and we had been preparing for this wonderful expansion of our hospital footprint. So our hospital was originated in 1929. The original building is still up. Parts of the original building are set to be coming down in the next 6 months. So we are in a constant change mode. So that the only constant is change is really a lived experience that we have here at the hospital right now. In the winter of 2023, we opened our new hospital wing, which is a large, very beautiful, large, big space that pretty much tripled the size of every unit that is in that building, which meant that nurses got to walk a lot more between rooms. Every room is private. It's beautiful aesthetically, but it does create challenges when you think about that total system safety. So just to put it in context, there is a lot of change. Units are changing every few months as we get ready to take the old building down and start to build a new building in its place. There's a lot of change going on, and a lot of change. So being a new to practice clinician or a nurse, you're not only wondering where the washrooms are, but even your peers might not know where they are because everything is moving. So next slide, please. We're also fairly big. So the footprint went from a 300-bed hospital to a 500-bed hospital, and now it's a 700-plus bed hospital. And so we think we're still in that culture where we're a small, tacit knowledge transfer happens a lot. We have great peer support. We have wonderful teams. We have a great sort of learning culture here, which is exciting. But we're growing really, really fast. And we also serve one of the most diverse neighborhoods in North America. So our little neighborhood, which is this little pie piece on the right-hand side of the graph, or the map, is really Toronto itself is second in diversity only to and new immigrants to their country, second only to Miami. So we have a lot of different newcomers to North America who come and settle in our area, and our little piece of that pie actually has the highest density of newcomers to Canada in Canada. So we do have quite a bit of community diversity. We have very high, like 5 of our 31 neighborhoods are considered priority neighborhoods or improvement areas, which means they serve individuals with low economic status. There's high unemployment, high unhoused. So we have a really quite diverse, and we also serve one of the most affluent neighborhoods in Toronto as well. So we do have we have to go the full spectrum of really new to Canada to individuals who have been here for multiple generations. Next slide, please. Okay. And so when we got the ECRI report this past March, we sort of took a step back and said, does this confirm some of the things that we were seeing? And so we were able to explore the signals in our data. So the first thing we wanted to do as a system was learn from ourselves, learn from our own data. So we actually ended up doing our patient safety culture survey we started it sort of shortly after this report, or just before the report went out. And so we finished it up just early in April. And what we were seeing, I'm going to share some of that data with you, absolutely confirms everything that Judy had said, many of the things that Shannon had talked about around culture and learning. And then I'm also going to share sort of our total system safety map that we worked with with our new to practice nurses. We also looked at our process to convene teams and develop action plans. We did that around each of the elements around the system safety approach. And then we also applied rapid improvement cycles and tests of change. Our goal is really to celebrate wins, because it's easy to focus on the negative, but we're finding that that resilience piece, that wellness piece, if we can focus and celebrate some of the wins, it creates a better culture and starts to create a culture, which you see we need to do a little bit of at my hospital. Next slide, please. Okay, so I want to talk a little bit about our patient safety element. So next slide. So during COVID, and even in the immediate sort of, or the next few years after sort of our peak exposure to COVID, what we were finding is that our infection prevention it was great. There was a huge focus on infection prevention and control practices. People were doing really well. Our hand washing was actually pretty good. And so some of our patient safety grades looked pretty good, pretty stable. Our CAUTI and CLABSI rates are pretty stable. We are looking at those as our traditional quality signals that we have a safe place to work. Our falls, again, were pretty stable. There were peaks and valleys in some departments, but those were immediately triaged. We did our system safety approach and really unpacked those. So our falls were fairly stable. But then we started to look at our reporting. So we had a really, really very robust reporting culture prior to March of 2020. March of 2020, all of a sudden we started to see a decline, and it really started to flatten out. And that reporting culture, again, in most hospitals, like most hospitals, nurses were the #1 reporters. They're the individuals who are really on the front line seeing those changes happen and putting something forward for that. We're also seeing very high turnover, and particularly turnover or really a lot of retirements of nurses with multiple years of experience. And that loss of experience Judy talked about, and we were seeing that, and we really felt it was a big signal. Next slide, please. So what this resulted in, when we looked at our patient safety culture, overall, we were doing okay, not great, but okay. But our biggest area of risk, and I'm going to say biggest area of risk that is of concern to everyone at the organization, is really this punitive response. I'm going to call it the punitive response to error. and the perception of punitive response. And these are just from our nursing cut of data. So I just wanted to make sure that you saw this. Like, this is, again, big signal, big opportunity for improvement. And what we realized when we did our review is that we really hadn't done a lot of safety culture support stemming from COVID. So it provided an opportunity for us to sort of restart our psychological safety activities. And our focus on individual and clinician wellness is one of those. Nursing and clinician wellness is a big part of that. Next slide, please. From an overall organizational, we did use some of the workforce safety as well as the burnout supplemental bundle of the AHRQ survey on patient safety, and that supplemented the Canadian survey on patient safety coded items. What we were finding is that, yes, our staff are burnt out, our staff are exhausted. So all of those things that makes that transitional period even more challenging, we were seeing. So it just comes back to reaffirm. Next slide, please. And this was our total system safety challenges and opportunities map. This has something related to that external environment. And in Ontario, the external environment in the first 2 years of COVID also had the reparations from Bill 124. So we did have a large amount of nursing turnover because of pay. We weren't allowed to give people raises. There were things that we weren't allowed to give nurses raises. And so we're finally starting to have that shift back now that was overturned. So from a policy perspective, that was a really positive policy overturn for our nursing workforce. But we were finding challenges in tools and technology. All of this wonderful new building with all of its new technology was great, but it wasn't working as intended or as expected. So we had mobile devices, thinking communication is going to improve. Every nurse is going to have a mobile device. And what ended up happening is that the mobile devices were too heavy to carry routinely with all the other things that a nurse has to carry from room to room to room, particularly when you have 40 to 50 steps per room between each room. So there were a lot of additional challenges. So we're working through some of those unintended consequences of the workflow, the tasks, and just understanding how to work within a new environment. Next slide, please. So some hope is here. So what we ended up doing, thank you, I'm almost last slide, is bolstering nursing innovation. So we have an amazing nurse leader who is now our director of nursing innovation, and really focused on bringing that joy and meaning back to nursing. She has innovation leads and community resource needs and nurse resource leads deployed. So we have individuals with special training who are now deployed to different units to help those new to practice nurses transition a little bit better. They're able to answer questions and provide support and just-in-time training at the unit level. We are transitioning, or in the middle of a transition to primary nursing model. So one of the questions was if you had more time with a one-to-one model, or if a nurse had more of that whole continuity of care model for the patients. Well, that's one of the models that we felt could really help answer some of the nurses' questions that we were challenged with. And we have a huge focus on nurse retention, particularly around stay interviews. No more exit interviews. We're focusing on stay interviews. What can we do different? And then there's also this idea of new education, competency-based education for knowledge and attitude. So some of that we are using simulation for. So we have a new simulation center in this wonderful new space. And now that's what we're using. And then we've completely retooled nursing orientation so that there's a lot more connection of the head and the heart, and some of that tacit knowledge transfer of on your first day, you just want to know where to go, find something to eat, coffee, the bathroom, and where to put my stuff. And so we're really being very mindful and having peer-to-peer support during that early orientation. So those are some of the big things that we're doing. And so I think next slide, the future is bright for us. We're quite hopeful, and our nurses seem to be very engaged in helping us design what that future is going to look like.
Thank you so much, Dr. Smith. We have some time left for questions. We're going to hopefully get through them all. If we don't, please know that we'll be getting back to you directly after the webinar closes. And we always remain open to speaking with anybody who's interested in this topic. So first question from Monica. When you look at newly trained clinicians from education into practice, does this include internationally trained nurses? And has there been any thought on that demographic to newly trained nurses in Canada? Maybe I'll, Dr. Ducher, yeah.
Oh, thanks. That's a super question. And I actually think we're making some strides in that area. You can look to Nursing the Future for a masterclass series that's coming up soon. One of the panels will be on internationally educated nurses and what are the challenges and how are we supporting internationally educated nurses? There's a lot of complexity to the IEN's transition, more so than the normal newly graduated nurse. And it's certainly worth a lot of discussion, and please look to NTF for that. But the cultural pieces are really significant. You don't just transition into a job as an internationally educated nurse. You're transitioning into a new culture, a new community, a new language sometimes. So there's so much more that's distracting your ability to transition in a healthy manner. And a lot of times these transitions take a very long time. The stats on how many internationally educated nurses we have in Canada that are not employable or not being employed, if they are employable, is astounding.
Thank you very much, Dr. Ducher. Ryan asks, I'm wondering what ECRI is doing to promote patient safety education to organizational leaders who still consistently undermine cultures of safety through their need to blame. And we talked about punitive cultures and constraints in the presentation. Shannon, I'm wondering if you can speak to this.
Yes, absolutely. And so we talk a lot about just culture, and we hear a lot of organizations that are implementing just culture programs, but we don't see them successfully implemented or sustained. And so we are doing a lot of work with both clinical leaders, safety leaders, operational leaders to truly understand what their role is in clinical and safety operations. And when we talk about just culture, it doesn't mean blame free, right? So this isn't, people are going to get off the hook. It's really about understanding what system factors led that individual to make that choice. And so this is not a skill set that comes naturally to a lot of leaders, I'll tell you, right? I think there's been lots of work done around this, and people, it's just human nature. We want to point blame. We want to find what was wrong. Why did that person think that way? And so when you think about training managers and leaders and really bringing in your HR business partners to be part of that discussion, it's really operationalizing how just culture should be with your institution. And it's not just training, because we know we cannot educate our way to safe culture either, right? You have to really integrate into your policy, into your procedure, into when an issue happens. Our managers, do they go through simulation? Do they understand the best way to approach this? Do they think in a systems way? That takes a lot of time to get them to rethink the way that they approach this, especially if they have grown up through the organization. So if you have a nurse manager who was a staff nurse, and that he or she was treated that way, they're going to likely manage that way. So we have to break that cycle. And so absolutely, we do see this as a huge priority. Thank you for asking that question.
Thank you, Shannon. We have time for one more question. I think it's very interesting to me, actually. And we were talking about pandemic dynamics and the pressures and realities that created. So this question is to anyone on the panel. Feel free to jump in. How much does the way the public treats healthcare staff impact the metrics that we've been talking about today? So public impression, public behavior.
I can jump in and just say a lot.
Lot. Yeah.
I guess the incidents of workplace violence have gone up. The other thing we've also seen is sort of that lateral violence, the staff to staff sort of disrespect as well is also growing. But I think it's all comes down to that level of we had resilience once and now we're really, really limited. Like our threads are very, very thin. So we have seen a higher number of incidents where patients are sort of needing to have supervision from our security officers based on their verbal abuse. So we get a lot of verbal abuse, and that has gone up as well. So I think that it does have a huge impact. We did ask some questions on that. Unfortunately, I don't have the data handy to share, but it is. We started calling this a couple of years ago, the culture of unkindness. And in some of our candor work, communication and optimal resolution work, and part of that, our way of sort of shifting towards how do we shift that culture to be kindness. And so we start with ourselves, and we're focusing on peer support programs as one of those ways to help really create resilience.
Thank you very much, Dr. Smith. We could talk about this for a lot longer. Fortunately, we are at time today. So if we didn't get to your questions, I apologize. However, we will reach out to you and get these questions back. And please give us a shout. Nursing the Future is a great organization in Canada. It's an excellent resource. Dr. Smith's work in Toronto is exceptional, and they're leading excellence in Ontario and Canada with the work they're doing, supporting new clinicians transitioning to practice. And ECRI is committed. We're a global mission-oriented nonprofit organization working in Canada and the United States, as well as many places in Europe and the Middle East and Southeast Asia. So please stay in touch. Stay tuned for more. And thank you very much.